Hi everyone, welcome back to the last video of this week lecture. In this video, we're gonna discuss on the pharmacotherapy of mania. Mania is a period of elevated or irritable mood with coexisting symptoms of increased energy, goal-directed activity, as well as decreased need for sleep. So in clinical practice, they differentiate this mania into three stages as stated in this picture. So the first stage, also known as hypomania, is the mildest form of mania, which is a stage characterized by decreased quality and quantity of sleep, irritability, as well as euphoria. The second stage, or known as the acumania, is towards a manic episode that characterized by lack of sleep, rash actions, lack of judgment, and in some cases, the onset of psychosis. And the third stages, which is the delirious mania, is the most severe of the three stages of mania and it requires hospitalizations. In terms of the treatment, the most common pharmacological properties of agent for mania is the lithium, which is the gold standard. Besides that, antipsychotic agents such as atypical antipsychotics can be used as combination to treat the mania. Aside that, anticonvulsants, which is the valproic acid, lamotrigine, and carbamazepine, also can be used to treat mania. So for this lecture, I will emphasize more on the use of lithium. Lithium is a small monovalent cation, as you can see in this picture, that rapidly absorbs from gut. As a metallic ion, it's not being metabolized and not bound to any plasma protein. This causes the drug has half-life about 15 to 30 hours depending on the renal function of the kidney. So it being excreted via renal, which is similar to the sodium ion, where being filtrated by glomerulus and reabsorbed back via proximal tubule and not in the distal tubules. Precautions have to be made. Lithium is very narrow therapeutic range, so the maintenance therapy, the level acceptance is around 0.5 up to 0.8 milliequivalent per liter. For those who are in the episode of mania, the clinician and pharmacy will target the level about 0.8 to 1.1 milliequivalent per liter. The toxic symptom can be seen if the level is more than 1.5 milliequivalent per liter. As I mentioned earlier, it's being excreted by the renal. It also can be secreted to the breast milk as well and can cross the placenta. So be mind to those who are plan to have pregnancy or want to breastfeed to the baby. So these drugs are not suitable to them. They also can cause drug interaction, especially taken together with the diuretics, which is the thiazide and furosemide, which will cause the reabsorption of the lithium in the proximal tubules, which will cause the increase in the plasma of the lithium levels. Not only that, it also can cause hypoglycemia when taken together with the sulfonylurea of drugs as well as the insulin drugs. Let's continue now with the effect of lithium at the neurotransmission level as well as potential the cellular mechanism. As we can see in this slide, lithium will modulate the neurotransmitters, will inhibit the excitatory neurotransmitters such as dopamine as well as the glutamate. Not only that, it also promotes the GABA-mediated neurotransmission. As you learned before, GABA is one of the neuroinhibitory neurotransmitter in the brain. At the intracellular signaling level, lithium will inhibit proteins such as PKC, MAXKS, GSK3, EPPase, and IMPase, which we've discussed further in the next few slides. As you can see in this diagram, lithium acting on the dopamine receptors. There is a hypothesis called the cyclical dysregulation hypothesis. This theory postulates that during mania episode, dopamine neurotransmission is increased. This elevated state will cause downregulation of dopamine receptors. A consequence of downregulation will be decreased the dopaminergic neurotransmissions associated with clinical depressions. So it will lead to the bipolar disorder. Postsynaptic activation of dopamine receptors is mediated by G protein coupled receptors, or known as GPCR. Chronic administration of lithium can alter the functionality of GPCR subunits. Because of this, dopaminergic neurotransmission is inhibited. Lithium also can induce the downregulation of NMDA receptors. As a reminder, the NMDA receptor is a subtype of glutamate receptor. So glutamate is an excitatory neurotransmitter that is elevated during the mania episode. After the chronic administration, lithium will induce the NMDA downregulation. This way, lithium will modulate the glutamate neurotransmission. We saw how lithium will inhibit the excitatory neurotransmission. Lithium also has the effect on the GABAergic neurotransmissions. GABA, as I mentioned earlier, is an inhibitory neurotransmitter that modulates the dopamine as well as the glutamate neurotransmissions. So in the bipolar patient as well as the mania patient, GABAergic neurotransmission has been reduced. So this image shows the presynaptic and postsynaptic effect of the lithium, which will increase the GABA level in the cerebrospinal fluid. At the presynaptic level, the lithium will facilitate the GABA release, and at the postsynaptic level, it will upregulate the GABA B receptors. Now we will discuss further on the potential cellular mechanism of lithium efficacy. So let's move to the left side diagram first. Lithium will inhibit the IMPase as well as the IPPase. These are two enzymes that are responsible to synthesis the myoinositol. So myoinositol is one of the signaling molecules. So this lithium will inhibit these two enzymes, which is the basis for the myoinositol depletion hypothesis. Let's move to the right chart here. So the diagram shows step after activation of G protein coupled receptor. The blue we can see is the protein kinase, MAR-CKS and GSK. So lithium will inhibit the PKC and its downstream target to the MRCKS. These two proteins has been linked to anti-mania effects. Lithium also inhibits the GSK3. GSK3 stands for glycogen synthase kinase 3, enzyme that involved in gene transcription as well as synaptic plasticity. So it is activated under condition of chronic stress such as mania. Finally, lithium facilitates the production of neuroprotective factors. So CREB transcription factor is a downstream target of adenylyl cyclase and is activated by lithium. So this CREB transcription factor will facilitate the production of the BDNF as well as the BCLT2. So these two proteins are the neuroprotective factors.